Well, great. Well, again, a final chance to really say my thanks really for the organizers for really tremendous hospitality and a wonderful meeting. Really a magical night last night. It's really been a great weekend, so it's been a huge pleasure being involved. So with my topic, they had really asked me to look and perhaps speculate a little bit in the future, as well as see other areas that are being studied in cancer and blood diseases and how they might affect MPNs. They may not be affecting them today, but these are clearly important areas of investigation. And I think what Nicholas Kroger said is very true. You know, we continue to really need to have good funding for, true biology-based research regarding mechanisms of progression and pathogenesis in these diseases to really create advances of the future. So I'm going to just focus on a few themes. First is really trying to target earlier disease and to delay disease progression. Claire alluded to earlier a study we had done both in the US and now we've done in Europe and other countries regarding the voice of the patient in terms of what's most important in your eyes in terms of the disease, as well as asking physicians. And there was a disconnect, and with patients in particular, the importance of trying to avoid progression. It's logical. If you have the disease, avoiding it getting worse is key. Indeed, it's a recurring theme as I visit with MPN patients. The majority of them, if they got no worse from the day that I saw them, they would live out the rest of their lives as they would have otherwise. It is progression in the disease that is a villain. Now, as physicians, we're taught very different things. Historically, we were taught primarily to avoid blood clots in ET and PVERA. That was the only goal. And then over time, with some of our efforts, people have become more attuned to issues of symptoms and quality of life. But you go back 10 years ago, and it's only about stopping blood clots. Doesn't matter how lousy you feel. Doesn't matter anything else. These are the preliminary data from the European landmark study or the international study that Claire and I led. And again, the feedback is very similar. The issue of trying to slow progression of the disease, clearly much more important in the eyes of patients than it is in physicians. Now, part of that has been frustration on the part of physicians. Well, I'm not sure that any of my therapies truly alter the issue of progression. And that is one of the greatest unmet scientific needs. Until we truly know why does that PV patient move to MF and then to AML, we don't know that yet today. Once we do, we'll probably be much more effective at being able to try to prevent that. So certain key themes. One, in terms of investigational studies, should we use drugs in earlier disease, particularly in early myelofibrosis? We've had good discussions regarding the therapy of standard myelofibrosis, but early in the disease, can we abrogate that progression in a progressive disease? There's early studies now using interferon to try to impact that issue of progression. Additionally, there is a study done here in Europe, of which I'm involved, which is looking at low-risk patients with myelofibrosis, but they're really not as low risk as we think because they're low-risk patients that have high-risk molecular features. So many of us have concerns. These people are likely to progress. Just watching is a concern. So it is a randomized study of ruxolitinib versus placebo with progression-free survival as the endpoint, trying to see, is that the right agent, is that the right thing to intervene with these patients. Next, understanding disease burden. I've mentioned quite a bit about symptoms, so we won't belabor this part, but I do think that this is an important part to really move from just being clinical trial information to really impacting our treatment on an everyday basis. It's now become really the standard in our clinical trial process, which is really an advance from the past. In the past, truly, studies in these diseases really did not account for patients' symptoms in any degree. Indeed, as we look at trying to measure symptom in these patients, we see that, again, we're doing it in clinical trials, but as we get aspects and ask patients about this, their physicians really typically are not doing this in any structured sort of way. So if patients are spending 10 minutes with their physicians, they get kind of the general question, how are you feeling? and are quickly moving to, poke on them and see if their spleen is enlarged, look at their blood counts, adjust their hydria and get them sent on their way. So it's a question that people ask, but they don't really have the time to have an in-depth discussion around it, which is part of the reason I advocate the use of the questionnaires, in that it can be at least an efficient way to convey that information. Now, assessing symptoms as part of practice is something that we now are advising. I led the US-based guidelines for how MPN should be treated in the US, and with this, we advise in patients with low-risk myelofibrosis, as well as all of them, to assess symptoms as well as risk. This is the first time we've really asked our physicians to be mindful if a patient is highly symptomatic, that has an implication regarding what therapies are chosen. And symptomatic low-risk patients, depending upon how symptomatic they are, considering intervention with medical therapy. Now, how symptomatic is symptomatic to need treatment? Truly, that's a discussion between a patient and a physician. We can statistically say that in our scoring system, questionnaire-based, it's at a 0 to 100 scale, 10 questions, 0 to 10 each. Patients that have a single item over 5 out of 10 or over 20 out of 100 are outliers. We can correlate those individuals with more significant disease features. But truly, it's like any risk imbalance. Is the difficulty that you're having significant enough that you're willing to try a medicine? Here are the potential side effects. And like anything, it's a dynamic discussion. 3 months in, are you really better off being on this medicine than you would be otherwise? If you have a copay for the medicine, is it really worthwhile for you to be on it? If you have a side effect, is it a side effect that's reversible? It's a very important part for all of my patients. Well, if I try it and if I don't feel well, does that side effect go away? Or is it a side effect that I'm stuck with forever? The same is true for patients with PVAR and ET in terms of these numerical thresholds. Finally, we've been analyzing additional information from other questionnaire-based studies regarding implications of MPNs on other sociologic aspects such as employment. And with this, we could find that there's a real implications, this is information we'll be presenting at ASH, that there are real implications in terms of employment. People will retire early. People may take positions that pay less. People can have different financial strain from having a chronic illness. Next, I would say a key area is multidisciplinary MPN care. I would say, and I continue to believe this, a good care of a patient with an MPN begins with a hematologist, but it doesn't end with a hematologist. There's other aspects of care that are important. One such example that our group has really identified, largely based on input from patient advocates, is the issue of mood disorders. There's a very vocal patient advocate in the US who really challenged us to say, I think that patients, in my interactions with many, many hundreds of patients online, that there's a lot of patients out there that are depressed, anxious, in addition to having the difficulties of their disease. We did this survey research with almost 1,800 patients who responded, so a very good sample size. And using questionnaires, we identified that there are much higher rates than the general population of depression, anxiety, stress, and grief. Now, this is not everybody, but this certainly affects a certain group of individuals without question. It is the uncertainty. I'm not sure what the future is going to hold. And it doesn't necessarily correlate just to stage of disease. It might be that early patient with ET that, again, it's the uncertainty of the future that can be a tremendous strain on them. And we clearly see that the issue of disease symptoms is not independent of this issue of mood. I definitely see patients who are on a medical therapy, they are better, certain symptoms are clearly better, itching, weight loss, etc. Yet other difficulties such as insomnia, anxiety, and fatigue may persist. Some of that may be inadequate treatment by the medicine. Some of that might be other aspects that need to be addressed. So in our clinic, we're very mindful of having integrative medicine specialists involved, psychiatrists and psychologists when appropriate, cardiologists, dermatologists, We've clearly have discussed about the increased risk of cutaneous cancers in patients with MPNs. Need to be mindful of a comprehensive sort of approach. Now with this, we're presenting data at ASH looking really at the impact of mood and individual symptoms, and again trying to tease out how each of these individual symptoms can sometimes be a clue as to unmet needs. Next, in terms of expanding medical therapy itself. So a particularly exciting area in cancer research is regarding immune therapy. The American Society of Clinical Oncology or the European Society of Medical Oncology, a full third of the scientific research being discussed is around immune therapy. So it's really been a revolution in those diseases, and is slow coming to myeloid diseases, and we'll get around to that in a moment. Now, with the immune system, there's a lot of ways to try to divide this up, so I'm just trying to give you a few brief concepts. One, our immune system does many things, and as it tries to impact our disease potentially, there are two segments. One, a part of our immune system is called humoral, where our B cells that are lymphocytes that create antibodies against bad cells. It's like going up to a bad cell, you put a flag on it for the body's immune system to come and destroy it. So it's going to identify that as a bad cell. The second is what we call our cellular immune system, where our T cells, different type of immune cell, are actually physical cells that they themselves identify a bad cell and have mechanisms of going and destroying that cell. Whether that's a bacteria, whether that's a fungus, whether that's a cell that has turned bad by being a cancer. Now, there are ways that we have historically used these sort of mechanisms to try to impact disease. There are antibody-based therapies that have been, in particular, very effective against lymphoid diseases, CLL, lymphoma, etc. There are others that PRM151 falls in this category that are trying to impact myeloid disease as well. And there are cellular-based therapies, one that has created great excitement in acute lymphocytic leukemias called CART therapy, where an individual takes T cells but tries to really enroll them to fight against a particular disease. Now, one of the challenges in individuals that have myeloid diseases is that in lymphoid diseases, those cells are important, but we are not as dependent on them necessarily as we are myeloid cells. The myeloid cells make our red cells, most of our white cells, and our platelets. So if we have an immune system that takes those cells out, we don't have enough residual bone marrow function to really make the cells we need for life. So we almost need Nick to come in with a stem cell transplant if we really take out those myeloid cells. And that has been a big scientific difference between the lymphoid cells that we can really reduce to a great number versus the myeloid cells. Now, the immune system has many different parts that are going to be investigated, both tumor immunity as well as balanced against tumor growth, and different aspects that we try to interplay. Many of our therapies have impact in here. Interferon is one of these therapies. Now, for an immune system to fight against a cancer, there are really three assumptions. One, that tumor cells have something on them that is different than normal cells, and that's actually been a limiter in myeloid disease that clearly is being studied. How do we separate the key myeloid stem cell that we need, that we can't live without, from the myeloid stem cell that is affected with the disease? Two, that the immune system can recognize this difference and that the response must be sufficient to destroy those cells or alter their growth. There are many ways that this is being acted upon. This is an example of the immune cycle where cells can release antigens, which are these flags that help to show that a cell is bad, where we could try to enhance the presence of these flags for the immune system to act in a greater degree, to where we're trying to activate the immune system response to a stronger degree against the cells that are bad, to where we try to retrain T cells to work against specific cells. This is the CAR-T therapy. And then the area that is having the greatest impact at the moment in solid tumors is trying to unleash the immune response with antibodies against PD and PD-L1, which is the programmed death receptor that to some degree helps to protect cancer cells. So it's a medicine to try to remove that protection from cancer cells so that the immune system can be more effective against it. It's now been approved therapy and very impactful in melanoma, in kidney cancer, and really a whole variety of additional cancers. Now, will it work in patients with myeloid diseases? We do not know yet. And there are reasons to say that this first generation may not be the answer, but it certainly is being investigated to see what else we can learn. There's some slides shared by a colleague of mine that's doing one of these initial studies where, again, they're looking at PD-1. If we block that protection of bad cells, will it lead to activity for patients with MPNs? They have been able to demonstrate in the laboratory of Anne Mullally, who's a prominent MPN scientist at Dana-Farber, that PD-L1 may be increased in the cells of patients with advanced myelofibrosis, as well as in their spleen tissue, so that there is some preclinical data to suggest activity. This first study, and it's a phase 2, so think about Nicholas's comments, exploratory in patients with early myelofibrosis to see whether this is helpful. I view this as experimental. Maybe it will help, maybe not. We hope with a study like this we'll learn more about, there's more tests that are done with a study like this to try to guide the next steps. The next that I would highlight is an area called CRISPR. Again, very experimental, but very intriguing in that it looks at treating the disease in a different way. Here, this is around gene editing. We know that the JAK2 mutation is a mutation. Can we go in and edit and fix that aspect in the DNA? This is being tested in certain diseases and in animals. This is a collaborative effort that has been specifically funded by the MPN Research Foundation and others. An intriguing area. The plus is, can it correct a genetic change? The challenge, as you've heard, around the complexity of the genes in these diseases, there's a lot of different genes that are being changed. Correcting even one gene may not necessarily get rid of the disease. So there's a lot of complexities, but well worth studying. Finally, I would comment on non-pharmacologic approaches. So our group has been interested in saying, okay, we're doing all of these things, but in parallel, what else can we do to help? So we did a feasibility study trying to look, we know patients have fatigue, we know that it's stubborn, we know even patients that respond to medical treatment can still have residual fatigue. So we recruited using social media patients interested in doing online yoga at home with modules specifically developed for patients with MPNs with modifications for enlargement of the spleen and other difficulties. So very unique, developed for this group particularly. With this, in about 40 patients, we identified, one, that it was feasible. People were able to do the yoga. They were able to follow the modules. They made sense, but they were able to specifically improve fatigue, anxiety, depression, and sleep, as well as increased activity tracked by blinded Fitbits. We now have a second pilot study which is accruing with 60 patients. Again, active yoga versus a weightless control that then will cross over to track both impact on symptoms, but as well biological markers from blood and from saliva that we can measure at home in terms of beneficial impact. Finally, cognitive therapy, acceptance and commitment therapy. I'm fortunate to work with certainly some expert psychologists in terms of trying to overcome some of these issues of mood. With this, there is an intervention that has to do with a variety of aspects of mindfulness to try to help patients better cope with their illness. This has shown improvement in chronic conditions as well as in cancer. There are 8 specific therapy topics that are done as direct face-to-face discussions. The first step is a pilot demonstrating its benefit in patients done face-to-face. The second step will be online modules to be able to demonstrate the feasibility of doing this at home. The first part is really, as I say, assessing feasibility. And the second is trying to prove improvement in health-related quality of life in patients undergoing this therapy. So a lot of different aspects. And with this, perhaps I'd like to conclude this final talk with a poem. This is a poem from a patient with PV who shared this with me. I asked patients really to share with me their gifts, their talents, as they reflect on their disease, as well as try to help other patients. I have an itch you cannot know, not the least hint will ever show. No bump, no rash, no insect bite, provides a clue as to my plight. My clothes a shower, the air I breathe, make my skin prickle and seethe. Constant reminders it provides of the disease my body hides. Maddening tears the burning brings, no scratch, no pills can stop the stings. Life is good, it could be much worse. I can live with my itchy curse. I walk the dog to pass the time, take deep breath and clear my mind. Pruritus is a small price for my wonderful blessed life. Thank you.